Hello everyone, let's begin with a new chapter, nutrition and fluid therapy. This is very important even in practical point of view, because as surgeons, day in and day out, we manage our pre-operative as well as post-operative patients, their nutrition requirements as well as the fluid management, correct? In simple words, let's first understand what happens when a person is starving. Okay, when a person is starving, the last meal that he or she would have consumed would have given him energy enough to sustain for around 12 to 14 hours. Okay, the glucose from the last meal. After 12 to 14 hours, once this glucose is depleted, what happens is that the body starts depending upon the glucose reserves in the body. That means the stored glucose in the body, which is nothing but glycogen. And where is the glycogen stored? Glycogen is stored in the liver as well as muscles. Both the liver and muscle glycogen, they get broken down, which is nothing but the glycogenolysis, and this will release glucose into the bloodstream. Now this is for the next 12 to 24 hours. Now after 24 hours, what happens? Once this stored glucose, that is the glucose reserves, are also depleted from the body, then the body will start depending upon certain other substances in the body, and they to convert into glucose, like the skeletal muscle protein breakdown begins, as well as the fat breakdown begins. This is nothing but lipolysis. Okay, skeletal muscle protein breakdown will release what? Amino acids, which are then converted into glucose. Which are the two important amino acids that are used to form glucose? That is glutamine and alanine. Okay, the lipolysis release, it will basically release the free fatty acids. So the fat is nothing but the chain of free fatty acids, right? So when you break that fat, you will get again the free fatty acids, which are then converted into glucose as well as ketone bodies. Now once, if the person continues to starve for more than 3 days, 4 days, 5 days, and so on, then what happens is that one important change that happens in the body is that some of the organs and cells, like CNS, then the red blood cells, then the renal medulla specifically. I think we have all learned this part in during our physiology classes in our first year, that all these are some of the cells and organs in our body which require continuous supply of glucose for their functioning, right? So what do these organs do? They start using ketone bodies for their energy, and then eventually they get adapted to using ketone bodies, and this is called as adaptive ketogenesis. This is called as adaptive ketogenesis. Okay, now this is in a nutshell what happens when we are starving. Now if you remember this flow chart, it would be very easy to understand this tables, both of these tables. Okay, let's look into this first table. What is metabolic response to starvation? That is basically when a person is starving, that is person is not consuming any food for a very long time, what happens? There will be low plasma insulin. You don't have to by heart these organs. You just, if this comes as a question, you just read the options and then start thinking logically. Why would there be low plasma insulin? Because food is the stimulus for release of insulin. When a person is starving, there is no food, so the plasma insulin will be low. And glucagon is the antagonist hormone of insulin, right? That's why there will be high plasma glucagon. Also to release for all those glycogenolysis and everything, this glucagon is important. Now in the liver, what will be happening? There will be glycogenolysis happening, protein catabolism is happening, right? Now hepatic gluconeogenesis also is happening eventually after the glycogenolysis, that glucose reserves are completed. Okay, now we have learnt about adaptive ketogenesis also, and reduction in the resting energy expenditure. Just keep I had for my exams, I had not remembered these values in particular, but I had understood the fact that when a person is starving, there is reduction in the resting energy expenditure. The basal metabolism would be slow. Okay, now so they have given another table saying metabolic response to trauma and sepsis. So we need to just understand the basic difference between starvation and trauma and sepsis. During trauma and sepsis also the person would be starving, but it is for various different reasons. Like here the person might be intubated, or the person might be unconscious, correct, low GCS score and everything, wherein the person can't eat for obvious reasons. He might be having endotracheal tube in situ and all such conditions, correct? So that is a very stressful condition. That's why you have all the stress hormones increased in the body, like adrenaline, noradrenaline, cortisol, glucagon, growth hormone, correct? Increased energy requirements in the body, because the basal metabolism would be very high to combat the trauma or sepsis that the patient is going through. That is why there will be increased energy requirements by the patient. Now so will be the nitrogen requirement. And in all, we have studied this in all the post-operative patients, in all the trauma patients, in all the patients under sepsis, there will be insulin resistance. That is because of the glucose intolerance. The insulin there will be adequate insulin produced by the pancreas is not a default here, and there will be adequate insulin in the peripheral blood also. But what is the problem here is that glucose intolerance, that is the in the periphery, when the glucose tries entering these cells, because these cells are insensitive to or resistant to insulin, they don't take up glucose inside them. That is basically body's way of reacting to the stressful situations, because body knows that the glucose is required for much more other important purposes in the body during trauma, sepsis and everything. Okay, then increased gluconeogenesis, this is same as the metabolic response to starvation. And the most important thing and the most repeated MCQ is that there is loss of adaptive ketogenesis in case of trauma and sepsis. Okay, I'll explain you why. This is because during stress trauma situations, the body will not use ketone bodies and requires only and only glucose for functioning. It is solely dependent on glucose for functioning, and if glucose is not available, body will shut down. That is why you see that is why if a person is simply starving on the roadside, all these poor helpless people, who are not consuming food for days and days together, if you see them, what is the difference between such people and the patients who are in ICU, who are intubated, who are in sepsis? What is the basic difference? These people, though they are not consuming food for such long time, they are not going into any sort of multi-organ dysfunction. But these patients, those trauma patients, if even for a day or 2 or 3, if they are not properly taken care of their nutrition or the fluids and the electrolytes, the body, all the body organs will start shutting down, which is called as multi-organ dysfunction or multi-organ failure. Okay, this is the major difference between starvation and trauma and sepsis, and this is multiple times asked as question in the MCQ form. Okay, next let's move on. This is another important table, though for the exam I myself did not mug up all these values and everything. I just remembered that what is must tool. Must tool, this word must, it stands for malnutrition universal screening tool. Basically a tool that can be used for screening malnutrition universally. Okay. um, so, and the three major things that it considers to assess the malnutrition: one is the body mass index, another one is how much percentage of weight is lost in 3 to 6 months, and acute disease effect, if the person is suffering from any illness or not. Okay. This is all that I remembered about this must tool, because it's really impossible to remember these values and the scores and everything. Okay. If you remember what is the full form of must, what why is it used for, and what are the three important things that it takes into consideration for the screening. Okay. I think that should be enough. Now, in three important ways of assessing nutrition in a surgical patient. Why is it important to assess nutrition in a surgical patient? uh, Suppose you have a patient with CA pancreas who you are planning for Whipple's surgery. Whipple's is such a major surgery that would last for around 6 to 8 hours. The patient should be fit enough to tolerate general anesthesia for 6 to 8 hours, first thing. Secondly, the patient would be having 3 new anastomosis, and the body should be capable enough to heal these 3 new anastomosis. That is why and patient would be kept nil per oral in the post-operative period for quite some time. Considering all these things, we preoperatively we need to assess if the patient is fit to bear these changes or not. Okay. So the 3 ways we need to assess the patient, if he can tolerate such a procedure or not. So how would we do it in a practical day-to-day scenario? First thing is um, first thing is to check clinically. I would first see the patient clinically. Is he very lean? How is his body mass index? And um, and the basic anthropometry. This I think is given in Bailey and Love in one of the paragraphs. I don't remember exactly, but basic anthropometry basically means all those skin fold thickness that we have learned in our community medicine classes. Skin fold thickness, the mid-arm circumference. Okay. And BIA something, biodectrical impedance analysis. Biodectrical definitely not used in day-to-day practice. None of these are used in day-to-day practice, especially in a government setup where the OPD daily OPD patient load would be more than 200 to 300. Definitely you can't and sit in the OPD and keep measuring a person's skin fold thickness or a mid-arm circumference. You would just look at his, at the max you would look at his body mass index. That is what is the weight to height ratio. Is the patient fit enough for his height? That is what you can check. Okay. Then second thing is that the lab investigation. The one lab investigation that you would look for is his hemoglobin level as well as serum albumin level. Okay. Again, some people say that this albumin is the best indicator of the nutrition status, but still you can't rely on it completely, because if the person has gone through a recent infection or inflammation, then the albumin level would have fallen in response to that inflammation, because it's a negative acute phase reactant, right? We have learned in our first chapter. Then okay, this is these two are basically the practically applicable things, but there are certain other things also which are usually not practically possible to be used in our day-to-day life, but just because it's given, let's just go through it once. That is, if you have to image a patient, if you have to use your imaging tools like USG or CT scan or anything, then how would you check? Is there any method to check for patient's nutritional status? Yes, USG. By doing USG, you can check a patient's rectus femoris mass, that is the thigh mass that you can assess. By doing CT scan, you can assess the psoas muscle mass, and there is something called DEXA scan, right? Dual emission X-ray absorptiometry, previously called as DEXA, now it's called as DXA. It is considered as the gold standard imaging tool to assess the muscle mass, but none of these things are used or none of these things are possible in practical situations. Okay. There is this another table, composition of the gastrointestinal secretions. Again, practically impossible to by heart all these values, but one thing that you can definitely remember is that saliva is very rich in potassium. What is the clinical significance of this, or when would this point come into your practically significant use? That is, suppose you have done an cervical anastomosis in a patient of CA esophagus. We do esophagectomy and gastric pull through surgery, right? Where we do cervical anastomosis. Okay, suppose this is the esophagus and this is the stomach. In patients of lower esophageal carcinomas, we do Watt's thoracotomy and we do the esophageal dissection part. We cut the cancerous esophagus, and then we create a new esophagus using this stomach, and then we pull this into the neck and we anastomose in the neck. Okay. So if this neck anastomosis leaks, basically all his salivary secretions would be lost in the neck, and in such a patient there would be lot of potassium imbalance in the post-operative period. Whoever is leaking through the cervical anastomosis, the potassium level would fall like anything, and that's why you need to replace potassium daily through IV fluids. Okay, that is why you need to know that saliva is very rich in potassium, and if a post-operative patient is having a leak where the saliva is being lost, then definitely you need to replace potassium. Okay, another thing that you can notice here is from duodenum till ileum, including the pancreas and the bile duct, all these things have sodium level of 140. correct. And pancreas is richest in bicarb. This is one thing that you can note. Okay, what is saliva is richest in potassium, pancreas is richest in bicarbonate. Okay, next, this is another important table, crystalloids and colloid solutions, the composition of these crystalloids and colloid solution. Again, we can't remember everything, even if we by heart this, we are meant to forget this during our exam. So just understand what is what, correct. Hartmann solution, which is considered as a universal solution, it has got sodium, potassium, calcium, chloride, lactate and everything, and it is the only solution which has got lactate. Okay, and if you can, it's better to remember the values of all these contents, but it's okay if you can't. It's nothing less in it. Okay, now normal saline, it contains 154 the amount of the sodium is 154 millimoles per liter. Okay, then another thing that is needs to be remembered here is that there is nothing called as ideal IV fluid. Okay, so my teacher used to tell me that ideal post-operative IV fluid depends on your local unit protocol, or whatever your HOU or HOD considers as the best IV fluid is the best IV fluid for your unit. Okay, that's it. Now, next, coming to the monitoring feeding regimens. This is another table that is given in Bailey and Love, and this is quite frequently asked in the mock exams as MCQs. That is, where if a patient is on parenteral nutrition, okay, that is, patient is not eating through his GI tract. Patient is not using any of his GI tract, oral cavity, stomach, esophagus. None of those things are functional. Directly the carbohydrates, amino acids, all such things are going into the blood. That is parenteral nutrition. If the person is on such feeds, or even if the patient is on enteral feeds but going directly into the stomach, like gastrostomy, feeding gastrostomy, or directly into the jejunum, feeding jejunostomy, there would definitely be so much electrolyte disturbances, so much imbalance in the fluid and nutrition status of the patient, right? So if the patient is hospitalized, then it's your duty to continuously keep measuring certain things. This also, again, you don't have to by heart this, just look at it and think practically. Is measuring body weight possible daily? Yes, of course, you can measure. You can tell the nursing staff to measure the patient's body weight, and it is possible to measure daily. Do we make a chart of input and output of the patient daily? Yes, daily during our morning rounds we make a chart, how much IV fluids has patient taken, how much is the output, how much is the urine output, how much is the drain output, how much has the patient lost in any other secretions, suppose leak or through the stoma bag. In the input we calculate everything, how much IV fluids you have given, how much fluids has gone through your antibiotics. Okay, if the patient is on NJ feeding or feeding jejunostomies, how much ml of feeds per hour the relatives are feeding the patient. Okay, all those input output charting you do daily, and that is needed. Okay, daily CBC and electrolytes and urea, definitely you can send these investigations daily, and it is necessary to send these investigations daily. Okay, and blood glucose, RBS charting 6 hourly. We get this RBS charting 6 hourly routinely in all our post-operative patients in our institute, because first of all, post-operative patients, they are prone for these insulin resistance and post-operative hyperglycemia, right? Plus, if the patient is on any of these parenteral or enteral feeds, further the patient can go into hypoglycemia if not fed during regular intervals. Okay, definitely urine output and the drain output and drain output and all those stoma output, everything we measure on a daily basis. Also the temperature charting can be done daily. Okay, if you get this as a question, and out of the 4 options, if any of these options are given, then you just think, is it possible for me to do this on a daily basis? Then, and you mark accordingly. Okay, you don't have to by heart this. If you can't, there all these weekly things, these are some things that you can't measure on a daily basis. Urine and plasma osmolarity, first of all, it is not available. Osmolality option is not, measuring urine or plasma osmolality is not possible in most of the government hospitals. Maybe it is possible in certain private hospitals, but it would cost too much, and you don't, there is nothing much you can do by measuring osmolality daily basis, right? That's why only weekly, if you check, that is enough. Calcium, magnesium, all these trace elements, then serum albumin level, LFT, then PTINR, APTT, ABGA, triglycerides, all these things. There's nothing much you can do about it even after you check it on a weekly basis. And these are certain things that you measure on a fortnightly basis, that is once in 15 days would be enough. Okay, this is just a picture that shows what is total parenteral nutrition, what is peripheral parenteral nutrition. Total parenteral nutrition you give through the central line, peripheral parenteral nutrition you give through the peripheral line. And this is the if you see a tube passing through the nose, then that would be a Rice tube, or it could be a NJ tube, that is the tube that is reaching up to the jejunum, crossing the duodenum, DJ flexure, that would be a NJ tube. Okay, or gastrojejunostomy, that would be another route of enteral feeding. Jejunostomy, feeding jejunostomy is another route. Okay, now one thing that you need to decide, or you need to remember before choosing which form of which form of nutrition to be given to the patient. That is, if you have to decide between parenteral and enteral nutrition, then first thing to be seen is if the person's GI tract is functioning. GI tract as in basically small intestine is functioning properly or not. If the small intestine is functioning properly, then you can go for any of these small intestine and stomach, gastrostomy, jejunostomy, NJ, you can go for these things. But if the GI tract in itself is not functioning properly, then you decide to go for total parenteral nutrition, wherein you have to give directly into the blood. Now, what are the complications of enteral nutrition? This is very simple. You don't have to, again, there is nothing much to discuss about this, because you're giving the enteral nutrition through tubes, right? Like feeding tubes, Rice tube, or nasojejunal tube, or gastrostomy tube. Definitely these tubes can be malpositioned, they can be displaced, or they can be blocked by the food contents. If you're giving, these are meant to be used for only liquids or slightly semi-solid liquids. Okay, but if you put all very thick contents, then it might get blocked, breakage or leakage. And because of the peri-tube leakage, there can be erosion of the skin and mucosa. Why would there be any sort of gastrointestinal troubles, bloating, nausea, vomiting? Because the amount of food that the stomach can tolerate and get distended is not the same as that a small intestine can tolerate, correct? If you that is why we give graded feeds through the jejunal feeding jejunostomies or feeding gastrostomies. If it is feeding jejunostomy, you start with 50 ml on the first day, 50 ml per hour on the first day, gradually increase to 100 ml per hour, then 150 ml per hour, then 200 ml per hour, like that. Okay, otherwise the patient will have sudden distension of the small intestine, which will cause diarrhea, bloating, nausea, all sorts of abdominal troubles. Definitely there would be metabolic and biochemical disorders, because he wouldn't be taking enough feeds through these during the initial days, and there can be any sort of infection happening. Okay, then what are the complications of parenteral nutrition? Parenteral nutrition, one is the related to deficiency. Again, not necessarily that all these hypoglycemia, hypokalemia, hypophosphatemia, um, uh, this is something called as refeeding syndrome. I would talk about this later. Okay. And the second complication is related to overfeeding. That is because you give everything in excess. If you give everything in excess, then there will be hyperglycemia, hypercholesterolemia, or and all the complications related to overfeeding. Then there can be catheter related sepsis, because parenteral nutrition is given through either the peripheral line or the central line. Catheter related sepsis can happen, or during the insertion of that line there can be pneumothorax, damage to the lungs, or some sort of air embolism, effusion, hydropneumothorax can occur. I have not seen any of the mock tests that I had given ask anything about this. This is but this is simple to understand, that whenever you insert an IV cannula, there would be endothelial damage that will cause vasoconstriction. If you continue to give fluids or administer any sort of drugs through the same vein that is already constricted, that will lead to further vasoconstriction, and it will activate all sorts of inflammatory and vasoactive mediators, which will trigger thrombus formation. It will occlude the vein completely, and when you continue to give drugs or heavy fluids through the same blocked vein, what happens is the drugs won't pass through the vein because it's already blocked, and it will start extravasating. It will go into the peripheral tissues, and then they'll peripheral tissue, and after it has extravasated, if you now remove the cannula and try inserting new cannula, you will be triggering this cycle of peripheral vein thrombophlebitis. This is called as PVT cycle. Okay, that's it about this chapter. Very small chapter, but very important chapter. The idea about the making the chapters into such small thing is that consistently revision is very important, and that would be only be possible if you take Bailey and Love and think that you will revise from Bailey and Love. It is simply not possible, because by looking at the number of pages in Bailey and Love, you will feel like not revising anymore. But if you cut this short into only 1 to maximum 3 to 4 pages, you can finish this in maximum 15 minutes. Okay, this entire chapter can be finished in 10 to 15 minutes, or the revision can be finished in 10 to 15 minutes, and that will boost up your confidence. Okay, thank you.